All right, let's go to Dr. Andrew Boozary. He's a University Health Network doctor in Toronto. Thanks for your time.
Thanks so much, Marilla.
As you heard, one of the main concerns being raised about privatization is upselling. So someone goes in for cataract surgery and then is told, oh, well, this would be a better product for you, or the service would be better for you, and then pays out of pocket. Is that a concern for you? And have you heard about something like that happening?
You really nailed one of the major concerns that we're seeing in terms of the kind of upselling that's taking place, and it's taking place across the country. And unfortunately, what we're seeing is various private and for-profit interests that try to take advantage of patients, really, and moving them to be thinking of them as consumers when there are opportunities to pay more for certain upgrades. And we saw that with the patient earlier in the segment in terms of being able to access some imaging or different quality, cataracts to hip replacement devices. And I think this is really concerning when we go back to the premise of universal health care or the Canada Health Act in terms of it being around the need and not ability to pay for these sort of upgrades. And we're seeing this disparity starting to take hold across the country in terms of people who can access or pay more, have better access. Those who are continuing to have challenges, as we're seeing with this widening income inequality, have poor access to healthcare, and they're actually the ones who have the highest healthcare needs. So definitely concerned in seeing this slippage and deviation away from the merits and values of the Canada Health Act.
So, Dr. Boozary, as you know, one of the reasons this is being looked at and is being done is because we have this huge backlog in Ontario of people waiting for hip replacements or knee replacements, and the province wants to get to them faster rather than have them waiting for years. Is there capacity in the public system as it stands to move these patients through?
There is capacity. The question is, are we willing to make the investments in our public health system or look at privatization and for-profit care as the only way to see advances or innovation? And I think this is where we've been conflating the conversation about what it means to address the backlog, what it means to see innovation, and also what it means to retain staff and nurses and health workers and recruit more. It will require investments inside the box. And I think what we're seeing is this false choice of inside the box or outside the box, and outside the box really being code for more for-profit solutions. And what we have to be very clear about is we have staffing shortages across the country. We've known about the vulnerabilities that we've had in place that were here before the pandemic, when we had lower nurse per capita ratios, lower hospital bed per capita ratios compared to other OECD countries before the pandemic. And of course, the stressors and the pressure that has been on the healthcare system and its workers throughout the pandemic has only made the situation worse. When you also look at the realities around retirement coming into the equation. So by bringing in these private or for-profit streams, or sort of seeing them as solutions, they're actually pulling away from the capacity that's already under a lot of duress. So we have to be clear about how we're actually going to retain, provide supports, and advance these issues in terms of the backlog, in terms of people waiting, trying to centralize these waiting lists and look at different innovations to actually address these real access issues. There's no other way to put it. The status quo is not working. We can agree on that, but it's going to be a question of, are we going to invest in our health workers and patients and caregivers and families, or are we going to start to see an opening for for-profit centers that can actually reap the benefits of the state that we're in?
Has there been any clarity on who gets sent where? I'm, Joe Smith, and I'm waiting for my knee replacement. Do I know if I'm going to end up at a private clinic or in the public system? Has that been sort of hashed out yet?
This is a crucial point. And I think when you look at the experiences we've seen both within Canada and outside the country, in terms of that individual being Joe Smith, it's usually around people who are low income, who are already facing marginalization, that do not get access to these new benefits and these new surges in capacity. And so that's something where we're not seeing a lot of clarity on as to how to ensure that these for-profit measures that come into place do not cream skim from patients who are wealthier, healthier, and not the ones who are actually needing the surgeries or care as much as many of the millions of other folks in the country. And when you look at the experiences in the United Kingdom, when for-profit solutions came into place, it's very clear again that it is not people who are middle income to low income, to people, to communities of color, to people already facing many barriers in accessing the public system that benefit from these measures. And that's something that we really need clarity on, or, alternatively, a real commitment to say, how are we going to ensure that people who need access to care are getting it? And we know what the solutions are. It's just that we can't see this confusion come into place with this for-profit sort of as a panacea or a silver bullet, when we know the experience in almost every jurisdiction points in the opposite direction.
Dr. Boozary, good to have you on this. Thanks very much for your time tonight.